Morning everyone, good morning. Typical British conversation going on in the chat. It has just been raining for months, hasn't it? It's just mad. Soon be spring, hopefully. Yeah, right then, let's get you going. Looks like everything's working okay my end. Where is it? There it is. Okay, so we're going to have a little bit of a recap of what we started last week, which was all about sciatica. And then I'm going to whiz through some of this because we've already covered it. So if you're not sure what it is and I've not really heard of it before, then we did a bit of a deeper dive last week. So just a superficial covering of some of these. Well, radiculopathy and referred. We're going to go over those very briefly just to set up the next bit of the session today. So there were a few questions from last week as well. So we'll just go over some of the answers for those as well, just to clarify everything. Hopefully everything will make sense. So we have, we were talking about sciatica and how sciatica is quite a poor, well, it's not a diagnosis, it's a sensation. And you can't say I've been diagnosed with sciatica because it's not a diagnosis. There are so many different, it basically means pain down the back of the leg. So it's, which can be coming from lots of different things. However, if you Google sciatica, then it will often come up with nerve root issues or disc herniations, that kind of thing. So just wanted to have a little bit of a look into that and a bit more detail so that we can kind of sift through what we need to be worried about and what we can talk about with patients and calm them down depending on the kind of symptoms that they get. So the reason why we've got this rain cloud up here, just grab my arrow there, just here, is this is from Tom Jessen. This is the way that he describes referred pain is like a rain cloud. So it's quite dull, it's quite diffuse, it's quite achy, it's that kind of sensation. It's not like radicular pain. Why is that not working? Which is like a shooting pain, like a lightning bolt. Okay, so that's why we've got the pictures up there. So the rain cloud, that referred pain, that dull, diffuse ache, comes from two main areas. And again, briefly cover these because we covered these in detail last week. So visceral, coming from the organs, and then somatic, which is from the bones, the cartilage, the muscles, the joints. Basically, the soma means the body. Okay, so it's coming from, not that the viscera isn't the body, but this is specifically from organs. This is specifically from all the soft tissue structures, if you like. But not, obviously it's to do with the nervous system, but it's not affecting the nerves directly. So this is a referred pain from the body. And why do we get it? We get it because of crosstalk at the point where the sensory information for that particular area comes into the spinal cord, and there is a shared nerve route for that information, and the messages get crossed, and the brain interprets the information coming from somewhere else in the body. So, for example, we have this one, which we talked about last week. This is a classic one called Kerr's sign, crosstalk example of the phrenic nerve. So the phrenic nerve coming from C345. C345, keep the diaphragm alive. And basically, if you have irritation of the liver, which then irritates or pathology of the liver that irritates the diaphragm, The information gets sent via the phrenic nerve to this area of your neck. There's crosstalk in this area of your neck with the same sensory input from your shoulder, and the brain goes, well, it must be coming from the shoulder. So you have shoulder symptoms when actually it is a liver problem. And that is a classic example of a visceral referral. It's the other one that we mentioned last week is a heart attack, where you have pain down the arm or up into the jaw. Obviously, that's not where the problem is. The problem is with the heart, but we get referred pain in different areas of the body because of the crosstalk coming from the viscera. So this is why when somebody has pain somewhere, it's not as simple as, oh, it's there, so it must be that. Okay, so it's we need to think about some other things. And one of the classics with this, I mean, if you think about someone coming in with shoulder pain that isn't to do with their shoulder, when you do an examination of their shoulder or you do any exercises, their shoulder is going to be fine. Unless there is a dual pathology where they do have a problem with their shoulder and they have a liver problem, that's when it starts to get a bit confusing. So yeah, you may have somebody who hasn't done anything to their shoulder. They've not fallen on it, they've not done any excessive exercise or repetitive movements. There's nothing in the history that would suggest that they've injured their shoulder. They are in maybe poor health, they drink a lot, and that, or maybe they have a history of cancer, so we may be thinking some kind of liver cancer or whatever. Then that kind of draws us away from the musculoskeletal side of things and draws us more into more of a visceral referral. But yeah, you do an examination of their shoulder and it moves okay. You poke and you prod it, nothing hurts. You have a feel of their neck, because sometimes it's a referral from the neck if it's in the shoulder. That's all fine as well, and that's when we start to think, okay, maybe it's something that's not musculoskeletal, it's not somatic, it's coming from the viscera. Okay, so that was that one. That was supposed to be a brief recap, but that was a long brief recap. And then we have radicular symptoms. Now these are this is interesting, and there was a really good question from Tristan last week about this, and I was thinking, actually I've said something there and I think it's right, and thankfully I was right, so I didn't give you wrong information. Yeah, basically this is an irritation of the nerve root or the dorsal root ganglion. So this is where sensory information comes in to the spinal cord, and just before it gets into the cord, there's a collection of sensory neurons which is called a dorsal root ganglion. It's like a bulb, if you like, a swelling of sensory neurons, and there is an ectopic impulse. So an impulse in a place where it's not supposed to be. That's what ectopic is. And it can be in the nerve root or the DRG, and this can then refer down the dermatomal pattern for that particular nerve root. Okay, so it's coming from the nerve this time, but the symptoms are felt down an arm or down a leg, whatever it is, and usually they're sharp and shooting pains this time. And it's because, if you think about this, so if there is an issue with your if there's something wrong with your finger, the information from that sensation will follow that sensory pathway back into that nerve root. And there are certain areas of the body that have got specific pathways, although they do cross over. So we've got even more confusion. It's not nothing is ever like, oh, it's that, so it's that. It's that, so it might be this or this. That's usually the way it is. So this is a classic one, especially for the neck area. Have you ever had that person come in and they've just got this naggy, in between the shoulder blades symptoms, and they're like, yeah, it just really kills in between the shoulder blades. Feel like I need to have a massage here, or I need my back cracked. It's that kind of thing. And actually, when you do stuff, there's nothing there. There's no symptoms, and it may be because it's referred from the cervical spine, and it's radicular symptoms from the neck rather than a problem with their rhomboids. Okay, so and classically it can go down the arm as well. So that is radicular pain, radicular symptoms. And then we've got radiculopathy. Sounds very similar to radicular, but this has got nothing to do with symptoms. This is to do with the loss of nerve function. So we have loss of reflexes. So if you do reflex testing, there may be dull or absent reflexes, a loss of touch sensation. So they've got just this odd sensation of an area of their body. In this case, we're doing the lumbar spine, so it'll be in the lower extremity. Maybe a loss of muscle strength as well. So a classic is a drop foot, where they can't activate the tibialis anterior muscle to actually dorsiflex their foot, so it drags on the floor, and they might not be able to lift their big toe, that kind of thing. And there may be nerve type symptoms too, potentially, but it's about the loss of nerve function. Okay, so the injury is at the nerve root, and that's why it's affecting all of the reflex testing and sensation testing. So we've got three different things, and the radicular and the referred are really common. The radiculopathy less so, but this is the one we worry about. Yeah, because if there is a loss of nerve function, and we're going to talk about how we lose nerve function in a sec, then if it is a significant loss for a significant period of time, you will permanently lose function of that area. And we talked about cauda equina last time, and the cauda equina is the bit of the spinal cord where it turns into a horse's tail. So we've got lots of nerves coming down into different areas of the body. And if there is a compression there, some kind of irritation there, then that can affect the function of your bowel and your bladder. So, and if there is a constant compression there, so the blood supply is cut off to those nerves for an extended period of time, you can lose complete control of your bowel and your bladder, and you may lose control of the musculature in the lower part of the body as well. So you can become paralyzed and lose bowel and bladder function. So that is why we need to know about this stuff, because it can be potentially life-changing. So so those are the three main things. Whenever you Google anything, you think, oh my God, it's this one. And thankfully, it is less likely to be this one. It's more likely to be the other two, but we need to know the differences so that we can rule it in or rule it out. If you don't have the scope or the skills to test this stuff, you have to refer people, because they need to get tested quickly, and especially in the case of cauda equina. And we will do a session on that. If you've never heard of that before, then definitely have a look. The issue is, though, that they can often overlap, and this is where we finished off last week. So you can have a radiculopathy with maybe a bit of radicular and referred symptoms. So it's not just you'll have one without the other two. You might have one with another one, or one with the other two. You could have one on its own, absolutely, but it's very common for them to be mixed. So it's very difficult to pin one thing down as the reason for symptoms. And this is why we have to go through a specific check. Just had a message from Jane. One of my rugby lads dislocated his hip, compressed sciatic nerve for a few hours. He's had to learn to walk again and is struggling a year on. Yeah. It can be that quick. It's a medical emergency, especially with cauda equina. It should be seen really quickly. There are some things which I'll point out when we get to that section but something to look for is something called safety net. So if you Google safety net NHS, we've got that in the UK. And if you sometimes you may have one or two of these symptoms, and you think, oh, is it not? I don't know. Should I refer them to A&E, or do I want to scare them? It's not looking like a clear picture. So there's a safety net card that you can give to patients, and if their symptoms change and they have any of the symptoms that are listed on that safety net card, they can take that card to A&E and they can say, look, I've been having these symptoms, and they should have an emergency MRI. Okay, so that system is in place in the UK. Cool. Okay, so like we say, sciatica is a broad term. It means pain down the back of the leg for some reason. And I put shocks for some reason. It's not very specific, but then maybe that is a good thing, because pain down the back of the leg isn't specific. So is it useful? Is it not? It depends, I guess. It depends on the person and what kind of information that they feel they need, because it's obviously some people really like to know specifically what the problem is, but sometimes it's just not that simple to give them an answer. So we're going to talk a little bit about what can cause these nerve root compressions and or irritations, and specifically disc herniations. We've been talking about that for a couple of weeks. We had a look at this as well last week. So the different types of herniation. So usually it's a slow nature. And it's a radial fissures forming. So you can see this, a slight bulge here through some of the annulus fibrosis, and then it gets a little bit bigger, and then a little bit bigger, and then a little bit bigger, and then eventually it can completely come out of the annulus. So the information that you can give to people is that this is usually a slow progress. Because quite often you'll have someone who has disky type symptoms, and so that radicular type symptoms, and they go, oh, all I did was bend over to pick like a piece of paper up off the floor. So and then they're worried that their back is so fragile because all I did was do that, and then my back's gone. So the thing is with these, they're usually something that has been happening for over a long period of time. But the good thing is with that as well, because of that slow nature of it, the body can adapt too. So it can give you reasons why it's happened, with a seemingly something that was innocuous really, but it can also give people comfort because the body can adapt. And what we see on MRIs of people who have no symptoms at all is quite regularly some form of disc herniation. It's really, really common. So it's not as if every single disc herniation is symptomatic. That's just not the case. So you can often have symptoms and people have no idea what caused it, and this can freak people out a little bit, okay, because of that. The inciting event wasn't anything catastrophic. It wasn't if they had a crash or something like that. It's literally sometimes sneezing and it happens, or they slept funny and something happens. So we talked about this, the fact that the disc gets its hydration from the bones. So the bones below and the bones above, they have a blood supply, and that blood supply permeates through the subchondral plate into this cartilaginous end plate. So it's not a plate, it's not walled off, it's like a bit like a sieve, so it can pass nutrients through, and that is how your disc will get its nutrition. Some of the things to revisit is some of these words here. So the nutrients from the vertebral body is drawn into the disc via something called proteoglycans. Proteoglycans are negatively charged and they draw in water, which is neutral, from the bone marrow. Okay, so that's their role, is to keep the disc hydrated. Chondrocytes are cartilage building cells, and they help to build the disc. So when you're young and active, everything is nice and healthy. As we get older, the ability of our body to rebuild these structures gets reduced. So we have changes as we get older. And then we also have these MMPs, matrix metallopeptidases, easy for me to say, MMP enzymes, and these clear away waste. So we've got everything working together. And I think you may have seen this picture before. So the proteoglycans are like a delivery truck, delivering nutrients and hydration. Chondrocytes are your friendly builders. And then your MMP enzymes are your refuse collectors. So they're clearing away the waste. So what happens when we have a herniation? Good old 80s or 70s reference of that era anyway. So apologies if you're younger than me and you have no idea what that means. So when the annulus, those rings around the disc, have been breached, proteoglycans have a party, basically, and they suck in loads of water. So remember, that was their job. Yeah, and usually they get the hydration from the bone below and above, but now there's a hole in the annulus, so it's able to get it from the outside of the normal way. So what can happen then is the disc can double in its weight in as little as 4 hours. So it just goes and it just swells basically. And it took me a while to find this picture, but the delivery team have a party. Who'd have thought that there is a picture of DPD having a party on the internet? So the delivery team are having a party, and they're bringing in all of this nutrients and hydration into the disc, because that's their job. But all of a sudden, they've got access to loads of fluid. Okay, so that's what's happening there. And then when we have this herniation, it's not just the nucleus that will potentially herniate if it breaches the outside of the annulus. We've got bits of annulus in the herniation as well, bits of end plate, so that cartilage structure, and potentially bits of bone. So if you remember from last time, we looked at something called Schmall's nodes. So that's where one of the first places the disc can herniate is up into the vertebra, and you get this little bulge upwards through the end plate, and bits of bone fragment can leach off of that, and if there is a herniation through the annulus, that can leak into the space, obviously usually posteriorly. If it's a really big herniation, it can trigger the body's immune response to injury. Okay? So because it's like it's detected a chemical invader, basically, and that sometimes can help the disc reabsorb. So sometimes a big herniation is actually dealt with a lot better than a smaller herniation, but it's not always the case. Okay, but so sometimes it can be. So just because there is a bigger herniation, it doesn't mean that bigger is worse, because sometimes, like I said, the body will detect it quicker, and then the immune response will kick in and clear it away. Somebody did ask a little while ago about disc bulges and what's the difference between bulges and protrusions and all that kind of stuff. So hopefully this will answer that question. So disc tissue, which extends beyond the edges of the apophysis, so around the vertebral bodies, throughout the circumference of the disc, so more than 25%. Basically, it's spread. Okay, and you can have a diffuse bulge, so it spreads bilaterally or all the way around, or you can have an asymmetrical bulge where it's just bulge in one direction. So we can have a bulge but without a leakage, if you like. Okay, so that they can bulge without actually herniating. And then we've got protrusions and extrusions. So a protrusion is when the base, so the blue line in this image here, is thicker than the head, which is the red line. Okay, so when the base is bigger than the head, it's called a protrusion. Okay, so and this is the material that is herniated from the disc. And if it's an extrusion, it means that the head, so the red line, is bigger than the base, the blue line. Okay, so that's why they're called what they are. So if you do get somebody come in and they've had an MRI report done and they talk about protruding or extruding discs, and you're not really sure what that means, that's basically what it means. So they've measured it, and yeah, if it's wider than it is long, then it's a protrusion. If it's longer than it is wide, it's an extrusion. Okay, and then we have this, just move me there, which is called a sequestration. And this is a type of extrusion, but this time it's sequestered, it's now secluded. So it's come away from the disc itself and it's separated. Okay, so it's come out and it's in the vertebral canal. And this is obviously where your spinal cord will be, in around this zone here. So you can see it on a side view there. So basically it's come out, and now it's severed ties with the disc, so it's floating about there. Now, out of all of the information that I've read about disc herniations, this sequestration, where the disc material has come out, is often one of the most painful. Okay, or gives the most symptoms. So that is something to look out for on an MRI as well. Then we have this categorization, and if you remember back, I think it might have been last week or the week before, we were looking at the ligaments of the spinal column. One of the ligaments that we looked at in particular was this one here, this in green in this image. This is the posterior longitudinal ligament. So before we go on, let's just see if I can bring that video back up. Yeah, there it is. So this is it. This is the posterior longitudinal ligament. Worth having a bit of a recap of this. So this is on the back of the vertebral body. Yeah, quite a thick ligament that goes all the way down the back. And at the time when I showed you this, I said, remember this because it's going to be useful for later. And now is later. Right, so there's your vertebral body, the back of it there. These are the pedicles on the side. And we're going to cut through those to show you the back. There we go. So this is the back of the vertebral body, and then there's the disc. And then there's the posterior longitudinal ligament. Okay, so that's it there. So it attaches to the disc. Comes out to the side a little bit, but mainly attaches to the disc. Okay, now the reason why that's important is because when a disc herniates, it usually herniates posteriorly. So, and then because of this posterior longitudinal ligament, it can't usually go straight out the back. Yeah, which is quite a good design, because just behind here is your spinal cord. So if you have a disc herniation, you've got this extra layer of protection with the ligament, protecting it from impacting the spinal cord. So what will then happen is the material from the disc usually then gets pushed to the sides. And look what's around that area there. So this is where your sensory dorsal root ganglion is, and the motor nerves come out. Okay, so we've got this area here where we've got the sensation coming in and the motor coming out. And because of the posterior longitudinal protecting the spinal cord, we will often get a herniation posteriorly, but then laterally. So it will go backwards and out to the side. And that's where it will usually herniate. That isn't always the case though. So we've got contained. So a contained herniation is it's have not broken through the posterior longitudinal ligament. Yeah, so it's kept behind the ligamentous structure. So it's kind of protected the cord behind it. If it's uncontained, then it has actually broken through. Okay. Uncontained are surprisingly less trouble in the long run because the immune system can help with the clear up. We were talking about that before with the larger disc bulges. Actually, because of the increased immune activity, the body can clear it up a bit more easily. It's not always the case, but it's often the case. Okay, so sometimes you can be unlucky. So that's the difference here. Again, if you see contained versus uncontained on an MRI, or you've had one done yourself. So these are the areas where you can have a herniation. So centrally, which is not likely to cause radicular symptoms, because remember, radicular symptoms was an impact on the nerve roots, and the nerve roots are on the side. Yeah, centrally we've got the cord, but if it is, it can be a serious one because of cauda equina. Yeah, so at the level of L1, L2, it is still a chunky cord. Below L1, L2, that's when it starts to feather out and become the cauda equina. Okay, so sometimes central disc protrusions, because it's kind of like, well, it is like a horse's tail. So if you've got something pushing on something that is a solid, well, it's not, well, it is solid object. If you've got something on pushing on the solid object, then it can squish against other surfaces. But when it's all flayed out like a horse's tail, if I've got something pushing through, then the tail can separate and the protrusion can push through. So it will part the nerves and then it doesn't impact on anything, right? So it can herniate and it won't touch anything. Sometimes it can be unlucky, and it does, but it may just, the horse's tail part of the nerves will just move out of the way. So that can be a really useful design. If it's a herniation higher up, then it could impact the cord itself, but that's less likely. Usually you get herniations around the level of L5, S1 or L4, L5. It's usually that level, which is where the cauda equina is. Okay, so if it is a central herniation, then sometimes because of the cauda equina design helps not compress those nerves. Yeah, so it's really quite useful. We can have something paracentral. This is the most common. The annulus is weaker here. Okay, so that this is where it's not as well protected as well by the posterior longitudinal ligament. So the posterior longitudinal ran down the back of the disc, if you remember. So this is backwards and then slightly to the side. Yeah, so that is usually where you'll get a disc bulge, is paracentral. You can get them in the foramen, which is on the outside of the where the nerve roots come through as well. So that's really far lateral. These are quite rare, but they can irritate the dorsal root ganglion, which is the swelling of sensory neurons coming into the spinal cord. So this one's quite rare. This one's the most common. This one we would be really worried about if it was causing compression on the nerves, and we were getting radiculopathy presentation rather than symptoms. So loss of sensation, loss of motor function. So cauda equina issues, bowel bladder changes, motor changes, sensory changes, and they're usually around the genitalia. So it would be things like when you wipe your bottom, you can't feel where you're wiping, that kind of thing. Yeah, so you need to build those questions into your case history if you've got someone coming in with back pain. All right, it's important to make sure that you've asked those questions. Although one of the things, I did a talk with Daniel Lawrence, who's on the Physio channel, and this was a little while ago in COVID times during lockdown, and we did a whole session on cauda equina. And actually, when you have those kind of symptoms, rather than them being red flags, that one of the things that was said by the researchers was actually you're waving the white flag at that moment, because it's gone so far if you're getting those symptoms they're in real trouble. Okay, so we need to, if we can get early signs of these changes and get them referred quickly, then that's far, far better than waiting for these red flags. Okay. So what can happen to the nerves? What time are we at? Okay, so we can get mechanical irritation. So if you think about a nerve coming out of that transverse foramen on the side of the spine, let me just show you that. Here we go. So we'll just have a look at that. Just do a quick recap of this again. So we're going to have a look at the around the facet joints, around that kind of area of the lumbar spine. Here we go. So there's your spinous process. These are the facet joints at the back, zygapophyseal joints, transverse process. And as I spin around, let me just pause that there. Here we go. So this is the area we're interested in. This is where the nerve roots emerge from. Okay, so just from here. So you'll have the dorsal root ganglion, which is the sensory information, and then the motor part of the nerve as well. So there are two sections of nerve that come out of this area, and we will do a whole session on this as well. And then they both join together and then come out of this hole here. Okay, as a mixed nerve at that point. So you've got a bit where they're purely sensory, a bit where they're purely motor, and then they join together and then come out of here and then mixed. Okay, so that's the bit that we're talking about. So if you imagine that nerve coming out that is mixed as a a guy rope on a tent. Okay, if you push on a guy rope, it absorbs force until the peg comes out the floor, but it will bow. Yeah, it will give a bit. And if you think about that, if we've got mechanical forces pushing on a nerve, it will bow a bit. So it will give. It's not like it's a solid structure and it's not going to go anywhere. There will be a bit of give, but it can deform the nerve. So you'll get compression on the top, and then the underneath part, there'll be a stretch on that underneath part. So that's the kind of image that you need in your head. So if you imagine this is your guy rope on a tent, and then we've got a heavy object on that guy rope, we're going to get some bowing. Yeah, so compression. So in the body, this can happen to the nerves, and we can get a mechanical pushing, a mechanical compression on a nerve. And this is what usually we imagine is happening to a nerve root after a herniation. Okay, so when that disc is herniated and it's pushing on the nerves that emerge from that region, this is what we imagine is going on. We do, though, have a number of objects that can be within this space. So here is your nerve, right? So we keep with the rope analogy. You can have things like little bony osteophytes, so little bony growths around the joint space, which encroach on that space and make it a bit narrower. We can have ligament hypertrophy. So the ligament, if there's been an injury to that area and the ligament's been damaged, we talked about that with ligamentum flavum. When it's been stretched really quickly, or maybe there's been some impact or something, or just age as we get a bit older, they can start to hypertrophy. We can have some fat infiltration into that space as well, that foraminal space. And then also we've got our blood supply trying to get in to provide nutrients for that area and clear waste away. Okay, so we've got basically, again, this is from Tom Jessen. He calls it crowding out. So we've got limited space in this intervertebral foramen. So that hole that we just saw on the outside, there's this interesting term, and this always confused me when I was learning, when I did my osteopathy degree, a space occupying lesion. And I the way that it was talked about, I thought it was one thing, but it can be lots of different things. Okay, it could be a tumor that is crowding out. Okay, we've got these bony spurs, ligamentous hypertrophy, and so on. Okay, so we've got lots of different things that can close up that space and impact that nerve. Okay, so what then happens? So nerves are really blood hungry. They do not like having their blood supply disrupted. And when a nerve impulse is generated, we get this depolarization of a nerve impulse down the axon of the nerve until it reaches the end, and then it either goes into a muscle or a gland or whatever it is, or another nerve, and then goes along again. And as this impulse is sent down, it then resets itself, ready to go again. Okay, so that's what should happen. So the propulsion of the nerve impulse along the axon, which is this bit here, it requires energy. And because nerves are blood hungry, they need a lot of energy to transmit these signals. So they need a good blood supply. If we've got this mechanical deformation of a nerve, then it can cause a bit, remember that rock on the guy rope? It can cause a bit of a blockage of these nerve impulses. So what can happen is the nerve function doesn't happen properly, and basically the impulse doesn't really go along the nerve. It kind of fizzles out. So because there's a compression or some kind of irritation to the nerve, it's like when you set a firework off and it's wet and it just fizzles out. Okay, so it doesn't fire properly. So that's what can happen when a nerve is either compressed or the blood supply is interrupted. So we've got mechanical pressure on the nerve, and then we've got a conduction block, so something stopping it. And there are two types. We've got a reversible one and an irreversible one. And I'll talk about these and then we'll call it a day from there, and then we'll pick up next week. So this mechanical pressure, if it's a reversible one, it's because the compression or whatever it is that is causing this conduction block is only short-lived. Yeah, so it's only very brief. Whereas this one is continuous, and then this one is the problem. Okay, so let's have a look at a reversible one. Crossing your legs. Yeah, so if you cross your legs over, around this area here near the fibular head, you've got a very superficial part of the peroneal nerve, or the fibularis nerve as it is now. So if you cross your leg over and you catch it just in the right place, you will lose sensation in that area of your leg. Yeah, and it will be only for a very short period of time, as long as you uncross your legs. That is an irreversible conduction block. You've put pressure on a nerve and it's irritated the nerve, so it can't send its signals down, so it makes that patch of skin go numb. Yeah, so that's a reversible one, because as soon as you move, then it's all good. Okay, so we've got normal blood flow. The blood coming in is under high pressure. Oxygen is used by the nerve, so the nerve said thank you very much for the oxygen coming in, and then the blood going out is under low pressure, and it's able to come out, no problem at all. So normal blood flow into a nerve is all good. Okay, if we have congestion and stuff going on, encroaching on the space around the blood supply for that nerve, then we've got a drainage problem. Okay, so we've got high blood pressure coming in, the oxygen is used by the nerve, but because of all this stuff that's in the way, the blood is struggling to get out. So we can have venous congestion. So the veins backfill, basically, and so it creates a micro swelling around the nerve. And then that means then fresh blood can't get in. So we're not able to get oxygenated blood into that nerve so it can function properly. So the blood starts struggling to get out. We get a build-up of fluid, so edema, and we've got edema, mechanical pressure, venous congestion, which is a combination that is not good for the nerve. Okay, so we've also got positional nerve blocks that we do when we're doing clinical testing. So if we do a Phelan's test, so this one just here, then this is a classic nerve block. It's a conduction block, because if you've got swelling around the nerve, which is usually the case with carpal tunnel, and then you hold your hands in that position, and they've got to be in that position because it's got to compress the median nerve, then it will cause the symptoms in the distribution of that nerve, and that's why it works. But then as soon as you bring your hands back, it feels okay. Yeah, but because there's congestion around that nerve anyway, or some kind of encroachment on the space of the nerve, by compressing it even further, the clinical test is basically bringing on the symptoms. Right? So that's what happens with that test. So with this reversible conduction block, it's all good. There's no underlying structural damage to the nerve, and then once the edema or the blockage is cleared, then everything is good. Okay, so if we can get moving and start to move that fluid around, then everything is good. Okay, and next week, because we've run out of time, we will talk about when it's not so good. Hopefully that's been useful. Tried to intersperse a few of the videos just to make some of the concepts make sense. So if you've got any questions, then please feel free to fire them into our Facebook group. It's a pretty kind of, it's not, well, it is a bit of a heavy session really. There's quite a lot to kind of get your head around, but hopefully that's made sense so far. And if there's not stuff that you like and you have a think about it over the week and you're not too sure, drop a question in the group. Happy to re-explain it next time. So we're going to go for a part 3 next week, and hopefully we'll be able to finish off the spinal discs, and then we're going to have a look at the inguinal region and specifically hernias over the next few weeks then. So next week, finish off sciatica, and then we're on to the inguinal region. So see you then.